one of the key components of treatment for bipolar disorder is the psychiatric treatment for bipolar disorder, and I'm talking about prescription of psychotropic medication. And that's really your area of expertise. Maybe you can tell us what are the typical approaches with medication for bipolar disorder?
Well, I like to tell people that, as upset as they may be when they get the diagnosis, that the reality is these days we have medications that will quiet the symptoms, and if they will take the medications, will keep the symptoms at bay, will keep them stable, will prevent relapses, and that we do that with a whole variety of medications. And I try to tell people up front that all the research now shows that multiple medications are better than just one or two, and that if you will go along with the program, then you are more likely to get quieting of your symptoms and long periods of stability. And the names of the medications are somewhat of a misnomer. That the main set of medications we use are mood stabilizers. Those mood stabilizers come from two other classes of drugs. The primary mood stabilizers we use these days are drugs that were originally used for epilepsy. They're called anticonvulsants. And anticonvulsants worked on the membranes around neurons that stabilize them. They alter the flow of sodium and potassium and calcium, the various things that impact the electrical charge of a neuron. And they were originally discovered for epilepsy, and they help people with seizures, and it turns out that several of them are very good with bipolar disorder. And the ones that are typical...
Do we know why?
I don't think we really know. Mm-hmm. And I think we're learning more, but it's pretty clear that these medications will, and not all the anticonvulsants are effective in bipolar disorder, but particularly something called valproic acid, Depakote, Tegretol is the trade name of the drug, carbamazepine is the chemical name of the drug, but those are very effective as anti-manic mood stabilizers, meaning that they help reduce the mania and prevent the mania. And then the new kid on the block that I think most of our patients now take is a drug called Lamictal. The chemical name is lamotrigine. And that's an antidepressant mood stabilizer, meaning it affects more the depressed piece. If you're depressed, it'll help you come out of the depression, and it'll prevent recurrences of the depression. So those are one group of mood stabilizers, these anticonvulsant. Now, the old boy on the block, which is probably underutilized and most people have heard about, is lithium carbonate. And this was discovered actually a long time ago, after World War II, but it took a while to understand how the drug could be used. Initially, some people ran into some problems and they backed away, but increasingly it became the standard for bipolar illness. And back in the, say, 60s and 70s, it was the main drug, and now it's been replaced by the other mood stabilizers, but it may have been pushed out a little bit too much.
I find with a lot of the patients that we see, a lot of the young adults, they're concerned about taking lithium. They feel that lithium has long-term negative side effects. It's kind of gotten a bad rap, and I wonder if that's part of its underutilization. It has to do with patients' concerns.
Certainly, and I think that there's a little bit too much negative view of lithium, and part of that is because in the, quote, old days, which is when we were young, in the old days, it was thought that you had to use lithium at pretty high doses to achieve the effect. And a place you can see this is in Kay Jamison's work, probably one of the most widely known bipolar patients, but also bipolar experts. And she talks about how in the early years of her illness, she had to use the high-dose lithium where there were a lot of side effects. Well, what's been discovered is that even low-dose lithium will have neuroprotective effects, that you promote growth of new neurons, you promote growth of new neurons in your cortex. You also boost the synthesis of these things called neuroprotective factors, neurotrophic factors. And so now we can use low-dose lithium, minimize side effects. We can get a good therapeutic benefit from lithium without all the side effects, and again, you have additional drugs on board. So it's not uncommon for people to use lithium and Depakote, lithium and Tegretol. And you know the ones that we see most frequently in our patients here, lithium and Lamictal, which is so frequent we call it Lithictal.
Right. So, all right, you've got lithium, you've got the other mood stabilizers, which were previously the anti-epileptic medications.
Mm-hmm.
We talk about the depressive phase of bipolar disorder. Do people use antidepressants with?
Absolutely. Now, recently,
But isn't that dangerous?
well, recently there has been some work that says, well, antidepressants don't work in bipolar disorder. Antidepressants don't work in bipolar depression. They don't work as well in bipolar disorder as in, say, simple depression. Mm-hmm. But we mustn't forget that all of your antidepressants boost these neurotrophic factors. They boost things like something called BDNF, which is very important, brain-derived neurotrophic factor. So even if the antidepressant won't necessarily get you less depressed, it's still an important part of treatment regimens, because antidepressants also promote the growth of new neurons, particularly the growth of new neurons in the area of your brain that has to do with learning and memory. So antidepressants are an important part of the treatment. I suspect part of your question had to do with the fact that antidepressants, if used alone, can trigger people's hypomanic or manic reactions.
That's correct. That's
yeah. We have to be mm-hmm. careful with antidepressants, and the current recommendations are that you don't use the older first-generation antidepressants, the old tricyclic antidepressants, that they have a higher rate of triggering hypomanic reactions or manic reactions. Also, as we know, bipolar individuals are a little bit more at risk for suicidal feelings and suicidal gestures or attempts, and those older antidepressants can be lethal when taken in overdose. But the newer antidepressants seem to trigger mania and hypomania a little bit less, and you can't kill yourself if you take them in overdose. And the evidence is that they promote the growth of new neurons and these neuroprotective factors. So they're certainly an important part of the treatment. But the caveat, as you alluded to, was that you should take these drugs when you're on a mood stabilizer. We generally don't have people on antidepressants unless they're on a mood stabilizer. The mood stabilizers are your principal form of treatment.
So one of the things I find with you and the other psychiatrists that work with us here at the university is that most of the time you strive for the least amount of medications with the least amount of side effects, at least the least amount that works for an individual.
Yes, it's tailored. And a lot of people, understandably, and particularly young adult, and they're being told, I'm going to have to take multiple medications, and I'm going to have to be on these the rest of my life. And it's really upsetting. It's terribly upsetting. And what I tell them is that they want to think about these medications like clothes. We could all get up in the morning and we could put on a sackcloth, and that would take care of it. And we just wear this big sackcloth, and it would be easy to get dressed in the morning. We'd put it on, and that would take care of it. We'd own a couple sackcloths, and then we'd mm-hmm. go to work. Well, there's a problem with that, in that we'd probably trip on it, and it would get in the way when we're trying to write, or it would be kind of a pain. What do we all have? We all have clothes that are tailored to fit us. My shirt is tailored to fit my upper body. It won't work as a pair of pants. Similarly, my pants won't work as a shirt. And so we have drugs that are like clothes. And when you and I get up in the morning, we put on 5 or 6 different articles of clothing that are tailored to fit our anatomy. And that's the way you want to think of these drugs, is that each one of the drugs is tailored to fit a particular part of our neuroanatomy. And just like clothes, we want to get the combination that fits us. So I think if you looked at our patients here at Student Health, you'd see that it would be, I think we'd be hard-pressed to find any two patients that were on exactly the same medication regimen. The patients that are stable are taking multiple medications, and they're probably a little bit different. The doses are a little bit different, and that's what you look for. You want to take multiple medications at the dose that gives you the maximum therapeutic effect and the minimum side effect. And you're constantly working with combinations to find that combination that will give you stability over time, and minimum side effects. I think, too, there's one I didn't mention that, again, it comes under mood stabilizer, and it's something that scares people, is the other drugs that we use are the atypical antipsychotics.
Yeah, they hear the term antipsychotics, and they immediately associate with someone who is indeed crazy.
Yes.
And having psychotic thought processes.
Yes. And that's really unfortunate. And again, these drugs have these labels, and like antipsychotic, it makes people think, oh my God, I'm nuts. Well, an antipsychotic should probably be called a dopamine system regulator, and just like antidepressants should probably be called amygdala regulators, because antidepressants, as you know, will also work with anxiety. And the mood stabilizers, the anticonvulsants, should probably be called neuron membrane modulators, because they do more than just oppose depression, or they do more than just oppose psychosis. They really are tailored to work at different parts of the brain. And antipsychotics, these atypical antipsychotics, are mood stabilizers. And it's very common for an individual to be on one of these drugs
and
as part of their...
Some of those that you find most commonly used are?
Well, the ones that people will hear about, particularly, say, if they're manic, one of the ones we use is Zyprexa. That's the trade name for a drug called, the chemical name is olanzapine. Seroquel, a drug that the chemical name is quetiapine. Abilify, aripiprazole. These are all atypical antipsychotics that are frequently used in bipolar illness. They're very helpful when somebody is manic. It helps quiet the mania. But a lot of them will, in small doses, contribute to stability over time. I have one patient that is very sensitive to one of the atypical drugs, risperidone. The antipsychotic dose is like 6 or 8 milligrams. This individual takes 1/4 milligram twice a day. And over time, we've seen that that has been crucial to her regimen. And if she backs off on a little bit, she'll get a little unstable. And she takes tiny amounts, and it's a mood stabilizer. She's not using it anywhere near the antipsychotic dose range. And so I think it's important for people to hear all of these drugs we use, not to think of them by their old labels, but to just think of them as bipolar stabilizers. Or I think that's a better way to think about it, as bipolar stabilizers or bipolar medications, because they're really doing a lot more than just dampening down psychosis or treating the depression. We know that they're doing a lot of things that are good for the brain, and I think this is a real important point that people need to understand, because once they get the illness, they can take these drugs, and these drugs are like keeping the oil in the engine changed and fresh. It's like they do all sorts of things to take care of the engine, to take care of the brain, and we increasingly know that.